I'd like to next welcome Dr. Rosanne Freak-Poli from Monash University, who's a senior life course epidemiologist, to talk about the complex concepts of measuring social health.
Thank you. And thank you for persisting. So, hi, I'm Rosanne. I'm from Monash University. I am interested to know, first of all, just exactly who's in the room, so I can get to understand my audience. If you just raise your hand when I say these words, you can put them up more than once. Anyone here from policy, primary healthcare networks, right? Hospital settings, excellent. Have a background in psychology, social sciences, and medical. Excellent. Oh, great. Now I know my audience better. Thank you. I am a life course epidemiologist, as JR mentioned, which means I'm interested in factors across the life course that impact our health. I'm interested in how these things change. We're not the same people that we were, say, 20 years ago, and sometimes when we're looking at data, we forget that. And I'm also enjoy a focus on social determinants of health, which is my interest here in social health. I've previously been funded by the NHMRC to assess happiness and health, very unlike them, and also funded by the Heart Foundation to look at social isolation and cardiovascular disease, which is where a lot of my evidence comes into play. So thus far, my contribution has been understanding the population impact of social health. I've demonstrated how social isolation is associated with a greater severity of chronic disease risk factors. So these are lifestyle behaviours as well as biomedical research, lower quality of life, increased risk of cardiovascular disease and dementia. And I've also looked at how social health interplays with once you get ill health, so when you've just had a chronic disease event, and how the interplay with social isolation, so social support in your recovery process. One of the fascinating things I found here is that your peers could be a negative social impact, which we don't talk about very regularly. So if you're going through recovery and you're surrounding yourselves with people who are, say, unhealthy lifestyle behaviours such as drinking and smoking, it's much harder for you to adopt those behaviours, and we should be aware that potentially that's another opportunity to engage people around changing their peer groups. Most importantly, I've been assessing social isolation, social support and loneliness separately, which is what I'm hoping to share with you today. As an epidemiologist, I love numbers, I love interpreting numbers, I love looking at how people have measured these and come up with their understanding of what, say, social isolation or loneliness is. And I'm going to share today about how we are currently measuring social health, how we interpret these measures, and then potentially how we could be doing them better. So these are a bit rhetorical questions. For the interest of time, I'm not going to ask the audience, but if you have an inkling at what you think is an issue, at what point loneliness is an issue when we're talking about severity and frequency, please contact me. How about how much socialising is enough for people for their health? What's the public health message here? What are we saying to people when it's enough? And is enjoying solitude, so this is someone who's not lonely, but they're also not socialising. Is this actually an issue for people's health? I'm going to start with the definition of social health, which is that social health relates to someone's abilities to adapt in social situations and form satisfying, meaningful relationships, and how someone interacts with and is supported by other people, institutions and services. So the most important thing here is it's not necessarily an individual issue, it's a societal or systems issue, and that we need to be providing opportunities for everyone to be able to access these, which is where social prescribing fits nicely, of course. This is not an exhaustive list of what we are interested in when we're talking about social health, but it is what I will use to demonstrate my point. So there are other terms such as social connection and social interaction, which have similarities but are a little bit different than these concepts. Social isolation I define as an individual's integration into their social environment, and it's measurable through things such as counts of social interaction, so it's an objective measure. Social support, on the other hand, is subjective, and it's about the degree in which people are utilising their social contacts. Loneliness is also subjective, and it's a view of insufficient social connection. So these are just broad understandings. I can give you much more refined definitions if you'd like to quote them. So when it comes to social prescribing, much of the grassroots work has been undertaken in the UK and here in Australia around loneliness. For example, ending loneliness together. And I'm sure that you can agree that social prescribing has benefits beyond loneliness, which is sort of what I'm interested in after the social health aspects. So first of all, I've got 4 points. The first one goes for a bit longer, so I am keeping to time, don't worry. So the first point is, do we want to keep these terms separate? And if you can't, if some people will be able to read my odds ratio graph there, if not, I've interpreted it for you. So essentially what I'm saying here, as an example, I'm using cardiovascular disease, that poor social health, that's either being socially isolated or having low social support and loneliness. People have a 42% greater increased risk of cardiovascular disease. But then when I separate out these terms, social isolation, or people that are socially isolated, has 66 greater likelihood, and people with low social support had double the risk. Loneliness wasn't statistically significant. And the point I'm trying to make here is that we really need to think about what we're aiming to do with our programs and how what's the aim overall, and then how we're going to measure it. It makes a difference with what the questions go into our surveys at the beginning, and maybe having a few questions that target each of these elements so that you can separate them out is beneficial. Also, when you clump them all together, what you're doing is watering down the true effect of social health on disease or other aspects that you're evaluating. So here, for instance, adding loneliness into the mix reduced the overall estimate down to 42%, if that makes sense. I can explain that in person later if anyone's interested. So then I go back to the rest of the literature and see where my estimates in my sample relate to. In 2003, the expert group of the Heart Foundation had a paper that said there was strong and consistent evidence of an independent and causal association between social isolation and coronary heart disease, but didn't have an estimate. So this was an expert working group pulling together sort of a rapid review data synthesis. And in 2016, there was a systematic review of 23 studies internationally that looked at social isolation and loneliness, unfortunately clumped them together, and showed that they were had 30% more likelihood of developing coronary heart disease and or stroke. So separated out the outcomes of stroke and coronary heart disease, but clumped together social isolation and loneliness. So that's actually quite close to my 42%. And because I love numbers, I'm going to show you this graph and I'm going to explain it to you. So this is my data set over time. So we've followed them for up to 6 years. And the line at the top, the red line, is the people's that are socially isolated and they've got a higher risk of getting cardiovascular disease. And the line at the bottom is not socially isolated, so got that lower risk. And you can see over time, these lines sort of get wider from each other. And what I'm trying to say here is that it matters how long we follow people for. So maybe if you'd done this study and looked at data at 2 years, you wouldn't see anything. So sometimes our social prescribing follow-ups are a bit short, maybe. So is it important to separate out health concepts? Yes. different constructs impact health differently. Potentially there's different causal pathways. I'm not going to go into that today, but some of my research does. And we're also diluting or watering down the true effect by clumping them all together. So what about these social health constructs in combination, or the interaction between these constructs? So if you look at loneliness on a scale of being lonely to not lonely and social isolation from yes to no, in the top right, you've got people that are lonely and socially isolated. It's not good, but it makes sense. In the bottom quadrant, you've got people that are not socially isolated and not lonely. It's good and it makes sense. But how about these other categories? You've got people that are lonely but not socially isolated. It's not good, but it does make some sense. We talk about this being alone in a crowd. And then people that are not lonely but they're socially isolated. Potentially these people just are enjoying their own solitude. Maybe they don't need as much social interaction as somebody else. So I've done this where I've added in also social support, and I've looked at all the different categories. And then I've looked at this cross-sectionally with health-related quality of life. So quality of life is someone's self-perception of their position in life. Here I'm looking at someone's self-perception of their mental health. And there's a discrepancy across when you look at all these in combinations. So the blue here I've got highlighted is the good social health as the reference group. And then you've got worse health-related quality of life, obviously, makes sense if you've got negative on all three. So this is someone that is isolated, low social support and lonely. But then in the middle, there's a discrepancy with where you sit. And one of the points I want to make here is that being isolated, having low support but not being lonely, so enjoying your solitude, is actually quite close to the people that are in good health when it comes to quality of life. Okay, point number 3. How best to assess social health constructs. So another issue that I have at the moment is a lot of these social health constructs mixed together, these scales, and also there's a lot of variability in subjectivity and objectivity. But there's this really great paper. Just to highlight that this is some of the stuff that we're going to be talking at Delphi. There's this really great paper from 2016 that looked at a bunch of social health measures and evaluated them. And what they did really well is did a figure for us to look at the degree of subjectivity and where they sit on function and structure. But to me, what it shows is how much variability there is in our scales, and potentially this is why we're seeing sometimes the effect or the association with diseases or not, or potentially that a program has is beneficial or not. So if we are using sort of more similar measures, it could be really helpful with us to then compare and optimise social prescribing in this case, or other lifestyle interventions. One of the points I wanted to make is, for instance, the Duke Social Support Index, which is right in the middle, has a nuanced sort of version where they've reassessed their questions based on our new understanding of separating these indices, and now they've got a social isolation indices and a social support indices. So it's potentially something that other scales could be doing, reassessing the questions and then separating out the terms. Fourth, final point, is the problem with scale interpretation. So in epidemiological research, measures are often classified as healthy or unhealthy, and this is based on their association with the risk of developing diseases. So true continuous measures are linear with equal magnitude between units. For example, when we assess blood pressure, for all intents and purposes, the units are considered equal, And the biomedical continuous scales are ideal for defining. We can put this into a system and it will tell us where the cut-off point is. It's harder to do this for socialising. Is 1 versus 2 versus 3 social interactions an equal spacing? Or how about 1 versus 2 versus 3 social supports that you can call on for help? So what we've been doing is generating these higher-lower categories, which are great for these general arbitrary comments saying that loneliness is bad for you, social isolation is bad for you, it's great to have social support. But they're not very useful at making comparisons beyond the sample, and there's no public health message there. So, does it matter, I guess is my question. I'm actually really eager to know how much loneliness is a problem, how much socialising is enough, is enjoying solitude an issue? Is that of importance for social prescribing? And I am continuing a little bit of my research in this field with my PhD students, Danny and Achimile, who are using some really awesome machine learning programs and artificial intelligence to look at cut-offs with the data set that I have around working out what these public health messages would be. But there's always more work to do if you have other data sets or if you're interested in this. We'd love to expand our capacity. Thank you.